Hi, good morning everybody. Myself Dr. Rajesh Patil here to engage you with yet another class on hepatobiliary system. I welcome all the students for this session. So today we shall be dealing with the topic jaundice. So this is important for you from clinical point of view and even from the exam point of view. Not really a 10 marks question on this, but obviously a sure shot of 5 marks question invariably can be asked on this particular topic. Jaundice. It is the yellowish discoloration of the tissues due to deposition of bilirubin which occurs in presence of hyperbilirubinemia. So this definition and basics of this you already have studied in first year subject physiology, and to brushing you up in few of the subheadings on that particular thing. So this is basically a yellowish discoloration. So what is the normal bilirubin value? 0.3 to 1.0 milligram per deciliter. The basic fundamental test advised by most of the physicians or surgeons, usually the pediatrician and physicians. Commonly done test, and it's a part of the liver function tests. Conjugated 0.1 to 0.3 milligram per deciliter, that's the normal value. Unconjugated 0.2 to 0.7 milligram per deciliter. So clinically, jaundice is evident when serum bilirubin crosses 3 milligrams. So and if it's below 3 milligrams, so most of the times, I'm telling you, most of the times, so it may not appear clinically. Clinically, yellowish discoloration of the sclera may not be there if it is less than 3. Okay, most of the times. Jaundice is latent, that is clinically non-evident, only detected by serum analysis when it is between 1 to 3 milligram per deciliter. So unconjugated hyperbilirubinemia is when direct bilirubin level is less than 15% of total serum bilirubin. Remember. So conjugated hyperbilirubinemia when direct bilirubin level is greater than 15%. So more than 15% of conjugated hyperbilirubinemia, it is conjugated when the direct bilirubin level is more than 15%. When it is less, it is unconjugated hyperbilirubinemia. So what are the sites clinically? So when you do your internship or in final year rounds, clinical side, bedside studies, so how you examine basically? So upper bulbar conjunctiva to be examined, okay, because it contains elastin which has high affinity for bilirubin, and even the base of tongue, most of you miss on this. Usually you see only for the conjunctiva. Even the mucous membrane, soft palate, base of tongue can be seen. Palms, soles, general skin surface. See, that is the reason, in olden days or some Ayurvedic doctors, they give some grains in the hands, in the palms of a jaundiced patient, and they tell him to rub that particular grains, may it be rice or jawar, and then keep that particular grains on the paper sheet. Then they'll show you, see, they'll be yellowishly discolored, these grains, and they'll tell you that they're removing your bilirubin. That's a false notion that they are giving. Some RMP doctors or some quacks, so they'll be giving you a false notion that they're removing the yellowish discoloration from your body. Why the grains become yellow in the hands or in the palms of a jaundice patient? Because of body secretions also contains this yellowish discoloration. Okay, so general skin surface. What's the differential diagnosis? Carotenoderma, so that's a difference one. Then intake of drug quinacrine. So what happens in carotenoderma? There is discoloration limited to palm, sole, forehead, nasolabial fold with sparing of sclera. So there won't be yellowish discoloration in the sclera. Okay, and like in case of hepatic jaundice. excessive exposure to phenols. So another differential. So this is a Viva question for you. What could be the differential diagnosis of a jaundice? So we'll have some basics here. Formation of bilirubin. See the heme component. Example, it could be derived from hemoglobin, myoglobin, cytochromes. So this is converted to biliverdin with heme oxygenase. Then biliverdin converted to bilirubin with biliverdin reductase. So this is bilirubin metabolism chart here. How this extravascular or intravascular hemolysis, wherein unconjugated bilirubin with albumin leading to unconjugated bilirubin transported with ligandin, so conjugated to glucuronic acid leading to formation of conjugated bilirubin. So in the hepatic sinusoids, okay, in the hepatocytes, and then moving on to biliary system. So wherein it is this conjugated bilirubin with the bacterial proteases being converted to urobilinogen, then that is excreted in the feces. So 10% of urobilinogen comes back into the portal vein. That is a process in small intestine. So here another urobilinogen again goes through the kidney renal system, converted to urobilinogen, excreted in the urine. So this is a schematic representation of the bilirubin metabolism. Such diagrams are very much, flowcharts are very much essential. Types of jaundice, 3 marks question or a part of a 5 marks question. Prehepatic, that is hemolytic jaundice, that is hemolysis, intravascular hemolysis, that is before it enters into the liver, that is prehepatic. Then hepatic, in the liver. Then post-hepatic, most of the times post-hepatic is related to obstructive or surgical. Hemolytic jaundice or prehepatic jaundice, here there is excess production of bilirubin due to excess breakdown of hemoglobin. So there is indirect bilirubin which is insoluble in water since presence of unconjugated one. Causes of prehepatic jaundice, hemolytic disorders, any disorder related with the RBC breakdown like spirocytosis, elliptocytosis, hereditary conditions with defect or absence of RBC membrane proteins, G6PD deficiency. So most common cause of enzyme deficiency leading to hemolysis, that is glucose 6-phosphate dehydrogenase. So autosomal recessive condition triggered by certain food, drugs, etc. So pyruvate kinase deficiency, second most common cause. Sickle cell anemia, wherein you see drepanocytes, sickle cell, the sodium metabisulfate test is needed here for diagnosing of a sickle cell anemia. Okay. So basically the hemoglobin, there is a structural derangement of this hemoglobin. So what happens, basically sickling of the RBCs due to low oxygen tension, increased hemolysis. Then acquired, where microangiopathic hemolytic anemias, paroxysmal nocturnal hematuриas, spur cell anemia, immune hemolysis, parasitic infections like malaria. See, most of the times clinically, jaundice patient, one of the important, we being in this part of the world, in India, commonest disease is malaria. So bilirubin, if there is yellowish discoloration of the sclera, just don't think of only in terms of liver, also think of the commonest parasitic infection that can happen to a patient in India. What is that? Malaria. So you should rule out this particular thing, the parasitic infection, by malarial parasite, Plasmodium falciparum or vivax. That's what common in India. Infective erythropoiesis. So cobalamin, folate deficiency like megaloblastic anemias, especially in vegetarians, wherein there is lack of consumption of these particular vitamin B12. Severe iron deficiencies, microcytic hypochromic anemias, thalassemias, increased bilirubin production like massive blood transfusions, resorption of hematomas, drugs like so many anti-tubercular drugs. Then coming to hepatic jaundice. So this is liver's ability to conjugate or excrete bilirubin is affected here. So there is increased level of conjugated and unconjugated bilirubin being present. Cause of hepatic jaundice could be any viral infections. So it could be fecal-oral transmission, HAV, HBV, HCV, HDV, HEV virus. So these hepatitis due to all these viruses can lead to hepatic jaundice. So the carrier state, the chronicity, the prognosis, it is excellent in HAV, whereas it is poor in cases of HDV and moderate in cases of HCV. Okay, so more lethal being HCV. So other viruses, Epstein-Barr virus, cytomegalovirus, HSV virus, herpes simplex virus. Alcoholic hepatitis, basically as you already have studied in earlier classes, there is ballooning degeneration, fibrosis of the parenchymal tissue. So more than 160 grams of consumption of alcohol per day for 20 years. Women are more susceptible. Remember that. The vulnerability is more in women, with the side effects of alcohol being more in women. Drug toxicity, acetaminophen, isoniazid. Then environmental toxins, vinyl chloride. So all these, the wild mushrooms also being implicated here. Wilson's disease, that is hepatolenticular degeneration, which we have already studied due to copper accumulation in the liver tissues. Then autoimmune hepatitis. Then inherited conditions. What are those? Gilbert syndrome due to UDP glyceronyl transferase. So basically this deficiency occurs here. Crigler-Najjar syndrome. So enzyme deficiency here. Direct hyperbilirubinemia, Dubin-Johnson syndrome, wherein there is mutation of a gene. Rotor syndrome. So all these. So these are the inherited conditions of a hepatic jaundice. Then comes the last type, subtype of jaundice, obstructive jaundice, wherein there is bilirubin formation rate is normal, conjugation is normal, wherein there is direct bilirubin. So any intrahepatic or extrahepatic condition leading to obstruction to the flow of bile. So any obstructive cases could lead to obstructive jaundice. So any outflow of bile being obstructed, any surgical reason or mechanical reason. So any extrahepatic obstruction leads to obstructive jaundice, whereas there is bilirubin rate of formation is absolutely normal. Causes of this obstructive jaundice: intrahepatic causes, viral hepatitis, fibrosing cholestatic hepatitis, hepatitis B or C, and hepatitis A, the Epstein-Barr virus, cytomegalovirus infections, alcoholic hepatitis, drug toxicity. So when there is cholestasis, so cholestatic hepatitis due to various drugs, then there could be chronic cholestasis due to chlorpromazine. The psychiatric wards can exhibit these patients in psychiatric wards. Primary biliary cirrhosis, all these parenchymal, diffuse parenchymal liver lesions could be obstructive. Okay. Primary sclerosing cholangitis, vanishing bile duct syndrome, where there is chronic rejection of liver transplants, could be seen in sarcoidosis, drug consumption, congestive hepatopathies, and ischemic hepatitis. So inherited conditions: progressive familial intrahepatic cholestasis, cholestasis of pregnancy, total parenteral nutrition in relation to, so all this contributes there. Benign post-operative cholestasis. So this cholestasis could be seen also in cases of benign post-operative conditions. Paraneoplastic syndromes, veno-occlusive diseases, graft versus host disease, infiltrative diseases. Examples: tuberculosis, amyloidosis, and even the lymphomas. And see there, again infections, commonly malarial or leptospirosis. Then coming to extrahepatic causes, that could be malignant conditions. What are those? Cholangiocarcinoma, gallbladder cancer, pancreatic cancer, ampullary carcinoma, malignant involvement of porta hepatis, benign conditions like choledocholithiasis, again obstructive, all these are obstructive, post-operative biliary strictures, primary sclerosing cholangitis, chronic pancreatitis, AIDS cholangiopathies, ascariasis. So even the worm infestation, Ascaris lumbricoides, could be an obstructive reason. Then what could be the signs and symptoms? The typical one. Early features, as I told you, yellowish discoloration of the skin and the sclera. So your neighbors can be your doctors in diagnosing this condition, especially, or your family members. They suddenly tell you, hey, what has happened to your eyes? It's being yellow. So in that way, this condition is patient friendly. So easy signs and symptoms are being exhibited, and very soon at earlier stage the patient can land up to their family doctors. Pale clay colored stools, dark urine, pruritus, remember that, pruritus. In late features it could be xanthelisma or xanthomas. Malabsorption, weight loss, steatorrhea, osteomalacia, increased bleeding tendency, fever, rigor, pain. So features of cholangitis can also be seen here. Now coming to investigations. So depends on etiology. So first and foremost, take proper history, clinical features. Then there could be the cause. So why there is sudden rise in blood plasma of bilirubin to be assessed. So normally it is less than 1 milligram per deciliter, and the values, as I already mentioned, are given there. So less than 1 milligram per deciliter, hyperbilirubinemia, greater than 2 to 2.5. So it starts diffusing into the tissues when it crosses 2. Okay, so clinically it is not evident up to 3 milligram per deciliter, as I told you. Then beyond 3 it is visible. The typical investigation will include blood levels of enzymes found primarily from the liver function tests, especially the aminotransferases, ALT, AST, SGOT, SGPT, and alkaline phosphatases, bilirubin, which causes the jaundice, and protein levels, especially the total proteins and albumin levels. So other primary lab tests for liver function include GGT, gamma glutamyl transpeptidases, and even the prothrombin time, which is very much related with the vitamin K. So pre-hepatic jaundice causes hemolysis of RBC, detoxification function test. So there is increase unconjugated bilirubins. So urine bilirubin absent. The unconjugated bilirubin is not water soluble. Okay. So the urobilinogen increased. Stool, fecal urobilinogen is increased. Rest of the parametry usually within the normal limits. Hepatocellular jaundice. So detoxification function tests. The serum bilirubin, conjugated and unconjugated, both are increased. Urine bilirubin present. The conjugated bilirubin is water soluble. Urobilinogen is decreased. Fecal stercobilinogen or the fecal urobilinogen is decreased. So the enzymatic test, that's the part of the liver function test again, SGOT, SGPT, or the AST and ALT highly raised due to lysis of liver parenchymatic cells. So alkaline phosphatase, GGT level is slightly raised. So all these glutamyl transferases are raised here. So AST and ALT rise is significantly higher than ALP and GGT rise. Remember that important one. The plasma albumin level is low, but plasma globulins are raised due to an increased formation of antibodies. So this is a chart being given here. The aminotransferases, the alkaline phosphatases, the albumin levels, the prothrombin time, depending upon what type of the disease, whether it's chronic hepatocellular disorders or the acute hepatocellular necrosis. So what happens to all these levels here? So such tables are very much essential. See that alcoholic hepatitis, the cirrhosis, the levels of ALT, AST greater than 2. So this particular is alkaline phosphatase, and then the albumin levels. So coming to post-hepatic or the obstructive jaundice. The detoxification tests, serum bilirubin, the direct conjugated one is increased, okay, beyond 15%, as I told in the earlier slides. So the conjugated bilirubin, that's the direct one, is beyond 15%, okay, hence it is called direct. So urine bilirubin is present, urobilinogen is absent, fecal stercobilinogen traces to absence. Enzymatic test, AST, ALT slightly increased, alkaline phosphatase, glutathione, gamma glutathione transferase is highly increased. So ALP levels, what are the normal values? Alkaline phosphatases 10 to 45 international units per liter. GGT levels 18 to 85. So in Viva, if you answer very beautifully, your slab of tough questions goes higher. In that case, they can ask you such questions. Tell me the normal range of levels of GGT or alkaline phosphatase. So you should be aware of this. This could be a Viva question. So this table here again showing you with these particular diseases and the levels. Radiological investigations. So the plain radiographs are of limited utility. So limitations here. Frequently calculi are not visualized because few are radio opaque. Okay. So depends upon whether these particular calculi could be visible or not, that really are the genesis for obstruction, the post-hepatic one. The most sensitive technique, so it could, the stones could be radio opaque and radiolucent ones. So henceforth these could be visualized or may be missed out. So ultrasonography, most sensitive technique for visualizing the biliary system, particularly the gallbladder. So procedure of choice for the initial evaluation of cholestasis and for helping differentiate extrahepatic from intrahepatic causes of jaundice. The CT scan helps visualize liver structures more consistently than the ultrasonography. But the CT scan has limited value in helping to diagnose the CBD stones because many of them are radiolucent. So if they are radio opaque, fine, absolutely fine, good. What if they are radiolucent? They'll be missed out. And CT scan can only image calcified stones, these can be seen. So cholangiography by the helical CT technique is also used here. So the MRI, MRCP, magnetic resonance cholangiopancreatography, important test, is used to visualize the hepatobiliary tree if very much suspected in cases of post-hepatic obstructive jaundice. It helps in detecting biliary and pancreatic duct stones, strictures or dilatations within the biliary system. It is also sensitive for helping detect cancer. MRCP combined with conventional MR imaging of the abdomen can also provide information about the surrounding structures. Example, pseudocysts, masses. Biopsy usually done at last in series of investigation to establish the cause of jaundice. So last resort. Okay. So in cases of apparent intrahepatic cholestasis, the diagnosis is often made by serology along with the in correlation with percutaneous liver biopsy diagnosis. See, always histological diagnosis, most of the times it's a gold standard diagnosis for especially the liver diffuse parenchymal lesions, the diseases or the tumors or the malignancies. To assess the condition of the liver tissue, it may have been damaged by conditions such as cirrhosis or the liver cancer, the hepatomas. So this is again the schematic diagram, the algorithm for patient with jaundice. Approach, proper history, do lab investigations, the liver function tests, alkaline phosphatase level, SGPT, GOT, PT time, the vitamin K assays, the serum proteins levels, especially the albumin. Then look for the elevation of the bilirubin levels. Then go for direct tests, the indirect hyperbilirubinemia test, wherein there is direct less than 15% of the conjugated bilirubin here. If it's more than 15% of conjugated, again it could be the direct one. So all these assays, the drugs, innate disorders, so shortlist on these and go on eliminating in a stepwise manner the differentials. The hemolytic disorders, ineffective erythropoiesis, then the hepatocellular patterns, then you can cholestatic patterns, the alkaline phosphatase levels when it increases beyond this thing, the normal ranges. Viral hepatitis A, B, C, do an immunoassay for the antigen or the antibodies there. Then toxicology screening, drug screenings. So all these assays, even the anti-nuclear antibody, anti-smooth muscle antigen, the immunological study, the antibodies assay for any cases of autoimmune disease association. So all this is a flowchart, the algorithm for diagnosis in cases of a jaundiced patients. The liver biopsy, MRCP, the last resorts. Treatment, general concepts. So what are the general concepts? So depends basically on the underlying cause, may involve removal of the offending agent, the first and the foremost one. Administration of antibiotics, antivirals, antifungal, surgery if it's in cases of blockage, the obstructive jaundice cases. Use of chemotherapy, anti-inflammatory or steroid medications. Dietary changes. So general treatment. So this is a dictum, general few lines there. Drink more glasses of water, eat raw fruits, vegetables, the green leafy ones, juices, drink coffee, not alcohol please. Do not drink coffee, no alcohol, and all these soda products, do not consume them. Don't eat junk food. Okay, so more juices consumption is good. Don't eat processed foods. So this is more than a jaundice, it's a general good lifestyle food habits that even a healthy person can follow. Okay, don't eat processed foods, white sugar, white flour. Use stress reliefs like going for walks in the park. Brown rice, millets are good. Avoid red meat, animal fats. So always avoid these beefs, the red meat ones, that is more prone for gastric cancers. So chicken, goat is okay to some extent, but always avoid the red meats one, the cow meat. Reduce dairy products, cheese, milk, and others. And fast few days. That is very healthy, healthy lifestyle. If you are fasting, that's basically a colon intestinal cleansing process. Get good sleep, exercise, do not smoke, and avoid even the secondhand smoke. Treatment of prehepatic causes. So G6PD deficiency, treating the underlying disease should be treated. If it's a spirocytosis case, should be treated with the phototherapy, exchange, transfusion, folic acid. So all this. So even sometimes resort to the splenectomy. So if underlying disease is sickle cell anemias, treat that first basically. So the avoid hemolysis there. Corticosteroids, folic acid is main line of treatment here. Parasites, treat malaria if the person is suffering from that particular thing. Ineffective erythropoiesis, treat with vitamin B12 deficiencies, especially if he is a pure vegetarian. See, vitamin B12 is always found in things which walk, swim, or fly. That basically means non-vegetarians. So they have got good vitamin B12 contents in their food, whereas the vegetarians miss it out. But still, vegetarians survive because they consume one non-veggie food. What's that? All veggies. That's nothing but the milk or the milk products that derived from cow. So the most of us consider that as vegetarian itself. That's another story. Treatment of hepatic causes. The viral hepatitis, treat the virions. So any viral infection, treat it first. So basic underlying disease to be treated here. Okay, that's what this particular slide conveys here. With the interferons or various cytokines. So again, different modalities of treatment depending upon the underlying disease. Wilson's disease, treatment with chelating agents like penicillamine. Treatment of obstructive jaundice. So supportive management. So what is the supportive management? ERCP, PTC procedures to be followed for biliary decompression. Intravenous administration of dextrose. Catheterization to monitor output. Broad spectrum antibiotic prophylaxis. Parenteral vitamin K, that's important one, or the fresh frozen plasmas, FFPs. Need careful fluid balance to correct dehydration. Correction of hypokalemia, if it's not corrected, it could lead to heart rhythmic dysfunction. Electrolyte imbalances to be corrected. So definitive treatments again. Choledocholithiasis, cholecystectomy is done. Carcinoma of head of pancreas, this could also be a cause of posthepatic obstructive jaundice. CA gallbladder, so Whipple resection done if inoperable. So radiological stenting is done. Choledochal cyst, excision of the cyst with reconstruction of extrahepatic biliary tree. Stricture, endoscopic stenting. So all these surgical procedures are being followed. So this is again a schematic diagram representation. The jaundice, take proper history. The physical examination, this is another flowchart of the algorithm of approaching to such patients. Extrahepatic biliary obstruction, ultrasonography, dilated ducts. So lab investigations basically here. Suspected malignant obstruction, then 3-phase CT scan with venous delay, then bile duct stones. If there are dilated ducts, think in terms of bile duct stones, then lap cholecystectomy. So all these ERCPs to be performed here. So what site is obstruction to be dealt, and then the surgical intervention. So intrahepatic diseases, the hepatitis screening, biopsy to rule out any diffuse hepatic parenchymal lesions. Thank you. So this comes to the end of the class on jaundice. So we conclude this particular session with a note, take home message. It's jaundice is an invariably 5 marks question in your exams and a very important clinically diagnosable disease, be it in pediatric department or in your medicine wards. Dr. Rajesh Patil here, signing off for now. Thank you, students.